So finally, we want to look at post-discharge support. When we look at this stage, you will find that there are different recommendations, but all the models recommend reaching out to the patient soon after discharge. Project Red points out that you could even have a staff-assisted patient helpline, and this is where the Bridges model really steps into its focus of making sure that the patient has a follow-up not just within 48 or 72 hours, but also in 2 weeks and in 30 days. So that's just a really quick overview, obviously, of some of these different components. I'm happy to switch the slides back and forth if people, would like to look at them or have them up while they talk about some of the things that they've been working on. So now, we don't want to take up a lot of time on our end. We really want this call to be about you all having the opportunity to share what you're doing and how you are improving your readmission. So we'd like to hear from you about best practices, successes with these kinds of approaches, also any challenges that you might have run into, because we have a lot of great people participating who may have some suggestions that could be helpful. So I'm going to stop now and ask you to help us out getting the discussion started today.
So, operator, you can open up the phone lines for questions and answers.
Opening phone lines now. Ladies and gentlemen, if you have a question at this time, please press the number 1 key. Ladies and gentlemen, if you have a question at this time, please press the number 1 key. We are waiting for callers to join the queue.
Hi, this is Maggie. I'm calling in from Michigan, and I have a question. I'm curious about how folks verify that the patient and families understand the discharge and aftercare plan. How do you make sure that, they're understanding, treatment after leaving the hospital?
It's a good question, Maggie. I think some folks might be using TeachBack. Is there anyone out there who uses TeachBack or some other approach to make sure that the patients understand the plans?
Our first question comes from John. Please go ahead.
From Utah and Salt Lake City. Largely, we do use the teach-back process, John, but we have found that, at least in HealthInsight, that following up, although they might understand it at that point, there, as you mentioned in your overview of your models, that you need to, touch base with them at those regular intervals. And in HealthInsight, we actually identified in our data reports to our IPFs, those days for them that have the highest amount of readmissions. So that kind of, helps their IPFs know, really when they need to follow up, even though they have the teach back, to know that the folks are following through. Thank you.
Thanks, Joan. We appreciate that. Any of the inpatient facilities, are any of you all able to comment on what you're doing to ensure that patients understand the discharge plan?
Our next question comes from Fund. Please go ahead.
Hi, my name is Fantasy, and I was wondering, when it comes to notifying primary care providers and other mental health providers about a patient's stay, is there any follow-up after that to make sure that the patient has been seen by those providers?
Thanks, Fantasy. That's a question for our inpatient facilities. Any of the inpatient facilities, are you all able to talk to that a little bit and let us know what you're doing to verify that?
Hi, this is Maggie again. I know in my experience, we've had patients, we'd ask them to sign a release if we knew that they were participating with a mental health provider. That way, we could incorporate it into, the discharge plan to make sure that we follow up. Has anyone else had success or used the same strategy for coordination of care?
Ladies and gentlemen, if you have a question at this time, please press the number 1 key on your telephone keypad. If you have a question at this time, please press the number 1 key on your telephone keypad. Our next question comes from Jane. Please go ahead.
Hi, this is Jane from Minnesota, and the question that I have kind of builds off of where Maggie was going with that. And, as we think about the recommendation for patients to get follow-up care, I guess the question that's coming to mind is the recommendation frequently to the primary care physician, or is it to a behavioral health specialist, or how do people typically make those recommendations? And do you do both? And how do you know if a patient actually follows through and is seen? Do any of the facilities that on the phone today, do you make recommendations to follow up with a provider? And do you have a way of knowing whether or not the patient is actually able to make an appointment and follow through?
And people can also ask or answer through the chat box as well, and we can restate it out over the phone lines if that's easier for people.
So this is Jane again, and maybe if the question about follow-up appointments isn't really catching hold and that's not where people want to go, I guess the other question that I've been curious about is within medication management, the degree to which, as a patient is being discharged, that the inpatient staff have access to certain information to help facilitate that transition. So, for example, how much is it known what the formulary for the patient being seen once they go back into the community, and is there an attempt to try to reconcile between the medications that may have been used within the hospital and how that might translate to what patients have access to once they're back in their community and covered by their health plan or by Medicare fee-for-service or whatever their coverage they would have once they go back into the community. Is that something that people have line of sight of? John, I'm wondering, would it make sense if we actually took a step back and just even talked a little bit more about people's relative background in using one of these models? Would that be something that we could maybe find out if people are using one of these approaches?
Sure. One of the things, Jane, that the reason we wanted to look at some of the core components was because I'm not sure people always use a model in its entirety, and so it would be interesting to know if people are trying to use one of these models as a guide, but we're also kind of trying to find out if they're just components of these models that they found particularly helpful. So that's a good question. Our call today is designed to be a sharing call so that our IPFs can talk with each other and learn from each other. So if you wouldn't mind sort of sharing with us a little bit about whether you're using one of these models as a guide for reducing readmissions, or if you're using some of the components from a model that you found helpful, we'd like to hear about that.
Hey, Dawn, this is Maggie. I was wondering, before we dive in, that's a great question. I would like to know just who's on the line, where everyone's from. I'm sorry I didn't bring that up earlier. Would that be okay if we could go around and introduce ourselves and where we're from?
Sure. I think if that would help, people get started talking a little bit about things, maybe finding out where people are from would be one way to kind of get a sense of who's on the call. So I have Shelley from HealthInsight in the chat. So maybe we can start with some of the LSQIN participants. Is there anyone on the call from Minnesota? A little hard for me to track whether I'm not getting verbal stuff. I don't know if people are putting things in the chat box.
And we are getting some things in chat now, John, so I can call out, we have Shelley Rise, and she has something that I think is a great resource. AHRQ has a toolkit for teachback at all literacy levels, and the IHI has information on how this method improves outcomes, which that's a great resource to use. And Carrie Ellis also commented that, she may go back to the follow-up appointment and MedRec with transitions of care, but it doesn't sound like she has a specific process. Carrie, if you wouldn't mind maybe expanding on that a little bit, but I know sometimes it is very difficult to always, follow up on all appointments of discharge, but any type of interventions or processes that you have on that we'd appreciate hearing from you. And we have some people introducing themselves, Carrie and Terry Luna from, Artesia General Hospital in Artesia, New Mexico. That's awesome. So glad that you're on the line. And I'm very sorry if I'm butchering anybody's name or anything. And Heather Berger from Thief River Falls, Minnesota. Nathan Meisner is from Albuquerque, and he works for the fire department. And here I'm working to implement a community EMS program in Albuquerque, I joined the meeting here to see what others are doing to improve outcomes. And there's Jane Gendron from Minnesota. And we did have the operator, operator, can you just have all the lines open at once, or do you have to just specifically queue a person?
If you want all lines open at once, I could definitely do that for you.
You know what? Let's go for it, because this
Okay.
is a sharing call, and I think people could be okay with that. So, yes, if you could please do that. Hi, Mindy. There's Mindy Foster from Vernal, Utah. And Dolores Johnson is from McLaren-Lapeer region in Michigan. Hello, Dolores. Hi. Okay. So I did like the gentleman asking about, and we do have some EMT, non-medical EMT services here in Michigan that help people once they're discharged from the hospital try and stay in the community with, much of it's referencing like medical interventions, but a few of them do some other things trying to help people with mental health issues. But if anybody has knowledge of that as a way to reduce readmissions, or if the gentleman feels comfortable saying a few things about that, that would be great. Let's see. And we have Carrie saying that we do follow-up appointments, and our outpatient providers let us know if our outpatients do not show up for an appointment, and this is very helpful to us. Thank you, Carrie. That's regarding trying to follow up with outpatient appointments that have actually been made, which everyone hopefully knows really does help with readmission rates when you can confirm that and help coordinate that and make sure that that happens for the patient. You see Nancy Vargan, Teresa Mentz, and Nancy are from Lincoln, Nebraska. Oh, this is awesome. We have people from all over, and they do follow-up phone calls as well. If somebody could say that, I know sometimes it's also hard to know, but do you feel that that's worthwhile? Do you feel that that increases success rate for people not coming back to the inpatient psychiatric facility?
Barb, I'm also interested if Teresa or Nancy could speak to this, who does the calls, and based on some of these models, are they done within 48 hours, 72 hours, or is there any extended follow-up like the Bridges program or the Bridges model recommends? Teresa or Nancy, would you be willing to sort of tell us how you all manage that?
We do the calls within 48 hours. And if they don't get a call the first time through, they do call back.
Okay. Yeah, and that can be difficult, right? To get the call through. Yeah.
Yeah, and sometimes the numbers that they give us don't really exist.
Right. Yeah, I think that's a common issue with mental health sometimes is the communication and, whether it's getting through on a phone line or whatever. Do you know, who is it that makes the call?
It's the staff on the floor that is taking care of the patient.
Okay. And would that be a nursing staff, or could it be?
It could be a nursing staff. It could be a tech, depending on the unit. And a lot of times it's who's ever had that greatest personal contact with that person.
Oh, okay. Well, that's
some people
nice.
connect better than others.
Yeah. So you actually have the people that maybe feel a connection to that patient trying to get in touch and check on them?
Yeah, I know that's what they do. A lot of times it's the nurse, but if there's a tech that has really made that connection better, then the tech will make the phone call.
Oh, that's nice. That's really nice.
And then of course, we make sure they have a follow-up appointment before they leave, and all that is documented. Mm-hmm. When and where and with whom and at what time.
Right. Well, it's nice that they get to talk to someone that, they maybe are more inclined to answer and talk with, right, and give a little feedback to, since it's someone that they connected to in the hospital.
Right.
Nancy, I'm curious, I know that there's been difficulty with access to behavioral health practitioners. Does it make a difference when you're making a recommendation that patients be seen after discharge? Do you ever recommend that they see their primary care, or is the recommendation that they see somebody in behavioral health?
they do recommend usually that they follow up with someone in behavioral health. There are occasions when they don't have a behavioral health provider, or they say they're never going back because they don't like that individual. I mean, that happens too. So then we do have them follow up with at least with their primary care, if at all possible. Or in the past, we have social workers that actually will help them get a new mental health provider.
Yeah, I don't know if you have a way, I know somebody was saying that they do have a way that their outpatient providers let them know, and actually I do see that. I think that was your group that was saying that as well, but I'm just assuming that if you're flexible in whether or not it's behavioral health or primary care, that does help just increase the volume of patients who are able to be seen by somebody.
Right. We really feel that getting them seen by somebody within that time frame is very important. That really decreases their readmissions, even if they refuse to see a mental health practitioner.
I'm sorry to do this to you, Nancy, but I appreciate your ability to talk with us. Do you have a program that provides a certain amount of medications for a patient once they're discharged to kind of carry them over for so many days?
We do have an assistance program that they can tie into, and that is not handled by my area, but they can get some aid for a period of days. I think it's maybe a 2-week supply.
That's great. Yeah, I've heard that can be very beneficial, to have that bridge for people with the medications as well when we're talking about the med-rec component. Many times, making sure that physician in the community knows the adjusted medications as well as making sure that they have all the medications that they were on while they were in the inpatient psychiatric facility as well, and having that continue for a while for them to, with compliance and all of that, it seems to help. So, thanks.
Sure.
Well, this is Jane in Minnesota, and I guess one of the questions that I have is, I don't want to focus the discussion on any one component if that's not what people are finding is the most important. So, out of all the things that John has reviewed so far, I'm just curious about which things people have felt like those were the most important to have tried to address, and which things were maybe important but are more difficult to actually implement. If people just have a sense of looking across this full range of interventions, if there's a sense of where do you focus, where do you feel like the most important areas to work on are out of all these components?
Hi, can you hear me?
Yes.
Hi, this is Shelley from HealthInsight in Utah. Actually, I just finished my master's degree, and readmission was the focus of my final project. My research showed that it was getting a patient, and this is overall patient, so it wasn't just psych patients, but getting them to see somebody within the first 7 days after discharge was the biggest factor to prevent the readmission.
That's really interesting, Shelley.
There's a lot of research out there, and also about the teach back as a best practice standard for discharge.
So making sure that the patient understood the discharge planning?
Yeah, I mean, teach back at all levels of, cognitive learning, where it's them telling the nurse in their own words what they've heard, because then it tends to stick in their mind better than if we're just, saying here's a piece of paper with the information. And that the studies are also focusing on how the patients are responding, in turn, because if they're understanding what the side effects are of the medications, the name of the medication, when to come back to the hospital if a medication is causing them to have, side effects or problems, then they should, call their doctor first or go to the hospital, whichever it is. But as long as they understand those medications, then the likelihood of returning is greatly decreased.
Okay, that's definitely an area I've been interested in. If someone would like to speak to that further, I'd certainly appreciate it. I've been talking with various folks about medication management and the importance of making sure that information is clear. One of the things that I've asked about, because it's part of our practice focus, is whether or not use of alcohol is included in a medication reconciliation, given the fact that it's going to impact especially certain meds that a patient may be discharged with. So, and we've also have questions about whether nursing staff does medication reconciliation, and in your comment, if they're using TeachBack as part of that, or we've had some places that actually have used pharmacists for the medication therapy management and use that approach to ensure that the patients understood what they had and what it was used for and how to take it.
John, can you hear me? This is Joan.
Yes, Joan.
We have not used pharmacists much in the West, and I'm just curious if there's anyone in the upper Midwest region that could comment on the differences they feel and the benefits the pharmacist brings to that versus the traditional approach with other staff.
Okay, do we have anybody on the phone who is using a pharmacist to assist with medication reconciliation?
This is Nancy at Bryant, and we use pharmacists to assist with MedRec.
So Nancy, are you finding that Joan was kind of wondering if you found that that's more effective than the traditional use of nursing staff, or do you feel like that's been helpful?
It has been helpful.
Are they using sort of the medication therapy management approach?
Yes, more so.
Do you have any sense if they're using a teach-back sort of piece to that? I think they do, right?
Right, they do a teach-back sort of piece to that.
Yeah.
And I mean, we're not able to do it 100% of the time, but they do try and do that.
Has your pharmacy department been online and been, sort of interested in trying to become a part of that process?
Yeah, and actually they hired additional pharmacists just to staff it.
Nancy, I was just wondering, sorry, this is Barb in Michigan. I was just wondering, is there a certain population that you tend to refer or that you see that it works well with?
Well, I'd have to defer to that pharmacist. I don't happen to know that off the top of my head.
Okay. Oh, that's okay. I was just wondering.
Yeah.
Sure.
Yeah, the feedback that I've got from facilities that are using pharmacists is that the pharmacists are generally very interested and excited about participating, and they want to be a part of the clinical team. So I think that's really good news. They're obviously continuing to try to find a way to be more effective in the process. So I think it's great that you all were able to incorporate them.
Yeah.
Well, this is Barb in Michigan, and I was just wondering if I see on the pre-registration that there was a group registered from McLaren Port Huron Hospital in Michigan or McLaren Lapeer, and I know that they're doing some interesting things with high-risk patients, that they have a special sort of group that gets together and, they have law enforcement, they have the probate judge, they have quite a few people, and I don't know if they included a pharmacist in that, but they've had some very good outcomes. I don't know if they're on the line today. Are they? If you wouldn't, maybe they're not. Maybe they didn't make it. Okay. But if anybody does anything for high-risk patients, such as like a sort of a community panel that gets together to sort of interface with each other, has anybody tried that approach? Okay. Yeah, they found it to be very beneficial. They had quite a few different people on this community panel: the Department of Mental Health, law enforcement, probate judge, some nursing staff from the Inpatient Psychiatric Facility, and community agencies would come together, and many times they all knew about the particular patient, and each one knew a piece of some of the issues that the patient was having, but when they all came together, it all was like putting pieces together in a puzzle, and they had the whole picture and could really help that individual not readmit again because they knew one part of it, but they didn't know the whole thing, and it was quite beneficial to them to reducing readmissions. But I was just wondering if anybody has something like that before, discharge, that they have people come together in a group, interdisciplinary team.
Barb, this is John. It's interesting that that type of team seems to be, whether it was intended to or not, addressing social determinants of health, right? Really picking up on all the different parts of a patient's life to try to see how to best intervene, right?
Yeah, that's a very good point. I never saw it from that perspective, but that's true. It is. It's looking at the whole person and all the issues that they might have.
Well, this is Jane in Minnesota, and, as we talk about teams and who's helping to support a patient as they leave the hospital the first time, one of the questions that comes to mind is the degree to which we're able to engage family in that. And I know I've heard providers ask and have discussions and questions around HIPAA laws and how it allows you or restricts the communication with family members at the time that somebody's hospitalized. And I'm just curious if others on the call have run into barriers around concerns that sharing information with family members, how that crosses the line or comes close to the line of sharing information, and whether or not people have had ways that they've been able to address that and have more open discussion with family members to help support the patient as they're being discharged.
It's interesting you bring that up, Jane, because Shelley also put that in chat. Are there HIPAA concerns with an interdisciplinary team?
Ah, okay.
I mean, I could speak to my understanding of the group that I worked with here in Michigan, in that I believe they have the patient fully aware of this group and that they sign a release at the time. That's what I recall, and most of the patients are willing to do that.
And I haven't explored this fully, and so this isn't certainly a legal declaration or anything, but my understanding from some of the work that we've done has been that if the patient is present, even if they don't sign something, that if they're present and they aren't asking for information to be withheld, that is sort of an implicit agreement, and that therefore bringing the family members in at that point is not a challenge to HIPAA. Are any people on the call sort of at the point of care during family conferences in the hospital that you would have more information about that?
Jane, this is Maggie from Michigan. I know in my experience, if the patient had a caregiver with them, I would, ask right then in the room, would you feel comfortable signing a release, allowing me to speak, with your mother or your daughter or whomever about your care. And I would say the majority of the time, people were receptive to that and willing to sign that release.
But Maggie, it did require an actual signature?
Yes, in my experience, just to cover my bases, I would always, have it on a document. Or follow up with a written signature. I may document if there was, verbal permission given, if it was over the phone, and then the next time I saw them, I just remind them that, you said it would be okay. You gave me that verbal permission to speak with your mother. Could you sign a release that I'll go ahead and put in the chart, and you can tear up this release at any time.
Mm-hmm.
This is John. I'm looking through the chat, and I noticed that Carrie Ellis had asked to go back to follow-up appointments and medication reconciliation with transition of care. Carrie, if you're still on the line, would you mind explaining a little bit about what you're looking for there? She's not on the line.
Well, John, this is Barb. The only thing I wanted to make sure that people were aware of in the chat way up at the top, we do have a handout with a link here, and that's our IPF best practice flyer. That there are a lot of the things that we've talked about today, RARE, Project Red, and the Bridges model. There are links in that to give you more details about those, as well as some other resources that we've mentioned, as well as things that we haven't talked about today. But all of that is in that link. If people are interested, they can go right there and find all the other information as well. So I just wanted to let people know about that too. That's what that's referencing.
Thanks, Barb. Yeah, I often, when I'm talking with practices and facilities, I often let them know that I found that RARE tends to summarize things a lot more, and you can sort of get more information as you dig into it. Project RED tends to be really comprehensive, and so I think sometimes people go in and find components like the Teach Back piece that was referred to earlier and use it. But it's very comprehensive. And then the Bridges model, of course, has this great focus on social work and really paying attention to the follow-up and community connections. So I would just invite everybody to go out and check out those different resources. I know Jane has mentioned that Project RARE also has a mental health specific component, and that might be helpful to our IPFs. So if there's nothing else for today, I'd like to thank everyone for joining us. As a reminder, the recording will be available on our Lake Superior Quinn YouTube page within the next week. We hope you'll join us for the next IPF sharing call on March 31st. The title is Risk Stratification and an Integrated Care Perspective in IPF Work. HealthInsight will be presenting on that one, so we're looking forward to that. I hope you can join us. This exciting sort of pre-readmission work and risk stratification tool that they'll be going through with us. Thank you so much for joining us today. Let me forward this slide. Okay, there we go. Let me put that up. Oh, it won't go back now. There we go. So there's the information on our next sharing call. Be 1 to 2 Eastern Time, 12 to 1 Central Time, and 11 to 12 Mountain Time. So we hope you can join us for that. We appreciate you joining us today.
John.
All right.